Hi, Dr. Kinderlehrer, Christina Bauer with the Texas Lyme Alliance. Thank you so much for meeting with me discussing some more information on Disulfiram.
You're welcome.
So overall, how long have you been using Disulfiram for Lyme patients?
I think the very first patients I started were towards the end of March in 2019.
Okay. And overall, your perspective has been?
I would summarize it as saying this is an incredibly powerful medication in the treatment of Lyme and Babesia in particular.
Okay.
That it appears to be more effective than what we have been using up to now. And it has potential side effects, and we need to be aware of its toxicity as well.
And that's what brings us to this interview today. So thanks for getting us jump started with that. Safety issues around Disulfiram for me has been a big deal. I've been witnessing about 15,000 patients or Lyme patients across the world, across our Facebook groups. And the one I have, just to mention for patients, I always forget this part, but Disulfiram Experience for Lyme on Facebook. But is side effects. How do people differentiate between having a herx versus a toxic side effect of Disulfiram?
Okay, so I would broaden the question a little bit to say that I see three big issues in terms of how we implement this medication. The first one, as you mentioned, is the herxheimer reactions.
Okay.
The second one would be side effects that are uncomfortable but not necessarily serious.
Okay.
Constipation or acne and so on, as examples. And then the third one would be real toxic side effects. We're talking in particular about nervous system toxicity. So we can come back to that.
Okay.
Your question in terms of how do we determine what's a herxheimer and so on, that's actually pretty easy when we start introducing the medication. I always start at low doses and not more frequently than every 3 days. So the average starting dose in someone who's doing reasonably well would be 62.5 milligrams every 3 days. In terms of people who are fragile, I might start at 31.25 once a week. Or if they're seriously fragile and I really don't want to risk that they're going to have any significant herx type side effects, I might put them on a compounded 15 to 25 milligram dose.
A week.
Once weekly, thank you.
Yeah.
And if they're going to herx, we usually know it at low doses, and we know what the herx looks like. Okay, herx reactions are not hard to decipher, and we usually, treat them like we do herxheimer reactions with appropriate binders and alkalinization and detox supplements. I should mention before we even start these patients on Disulfiram, we make sure that we balance their endocrine system, that we deal with food sensitivities. We deal with yeast in particular because, as you know,
yes,
yeast can be metabolized to acetaldehyde. And even though Disulfiram can fight yeast as well, I really want to knock any yeast overgrowth down. So these are things that we do ahead of time, but also I'm going to put them on some supplements to help protect them as they're on Disulfiram. And so most of my patients will be on some anti-inflammatories like curcumin, CBD, Boswalla. I am putting people on zinc and vitamin C, and this will come back to copper issues that you might bring up. If they have methylation or other detox problems, we'll clearly try to balance those and to try to normalize those pathways, and particularly liver support. So these are things we do ahead of time. So
important.
Yeah. But I don't typically see any side effects of the drug In terms of significant side effects, I'm talking about particularly nervous system toxicity until people get to higher doses. So we already know what a herx looks like. On the other hand, when people, and this is my experience, my patients, most of my patients are not over 200 pounds. In fact, I can only think of one offhand, maybe two that come to mind. I would say the average patient is going to be in the 150 to 120 area. And my experience with these people is that they do best on about 250 milligrams. And if they want to push the dose, I do it very carefully. And it's not unusual that if they go to 375, and that'll only be every other day that will do that. So alternating 250 and 375. And then they'll start to say, oh, I got some brain fog and I have some headaches or mood disturbances. I will immediately stop the drug and wait until they're better. And usually if we do that immediately, within 24 hours, they say, oh, I feel great.
Right.
We restart at the lower dose, in that case, 250 milligrams. So I don't typically see the nervous system toxicity until we get to higher doses.
How do you start those patients?
It's really unusual that I'll start someone at 125 every 3 days. Okay. So I would say my average patient starts at 37.5 every 3 days, and then a bunch also will start at twice that dose, 62.5 every 3 days. Those are my average patients. If someone is really, really doing well, is already on antimicrobials, has not been having trouble with herxing, I might progress that dose a little quicker, but those are exceptions. It's really usually between 32.5 and 31.25 and 62.5.
Sure. That sounds the safest from what I've seen across the boards. Mm-hmm. And then also I want to clarify that you're not increasing any dose within a 2 week time period, correct?
Yeah, good question. So even though patients will email me and say, I'm doing fine after I increase the dose, I say, no, we're going to wait 2 weeks. And I have patients emailing me, everyone, over 100 patients. They're emailing me every 2 weeks. And I ask them, okay, tell me what happened between now and 2 weeks ago. Send me a complete med list and tell me exactly what dose you've been on for the past 2 weeks, because I really don't want to look at the prior emails. Try to convince them to keep the emails in a chain so that it's easy to follow. And then I warn them from the get-go, if you have any significant herxheimer reaction, this is not something to plow through. Let me know immediately. We will cut the dose. If you have any side effect that's really uncomfortable, particularly a nervous system side effect, you let me know immediately. Don't wait for the 2 weeks. And again, at those lower doses, I don't expect any serious problems, and I haven't seen them. But I have to convince some patients this is not one of those situations where you just want to get quickly to the target dose and stay on it for 3 months and get off, because there's no question that the tortoise beats the hare here, and people who try to progress too quickly get into trouble.
We have a lot of information now before us with experience now to avoid it. That's the biggest thing that I want to get these videos out. So thanks again for doing that and helping patients that you may never meet. So the first thing I had in my notes was success rates. We had talked prior to this video about that a little bit. Do you have anything you want to say to the community?
Because I started late, compared to, say, Dr. Liegner, but I started in late March, and then I was away a good part of April, and so most of my patients didn't get started till in the spring and later. And of those patients, I'm going to guess about a dozen people who have completed the treatment. They are doing exceedingly well. Now, obviously, I have people who haven't completed the treatment who are still sometimes stuttering, and we're going back and forth a bit. But I have patients, and I know you've read what Otto said, and I love Otto. And it really just amazed me because before we started treatment, he thought he was in remission. I thought he was in remission.
Isn't that hilarious? I thought I was near remission. I know so many people I've watched that I've followed their journey, and I've seen them say it so many times, I'm near remission, or I'm 90%, I'm 80%, and they get on this medication and it's a brand new ball game. Like you've never treated a day in your life. And that's what happened to me.
Yeah, and Otto is 26 years old. He got sick when he was 18. It's not that long ago, but he said, oh my God, I forgot what it was like to feel well. I can't believe how much better I feel. And other people have said similar things, like, this is remarkable. This is the best I've felt in 5 years. It's really an amazing response. And it's very exciting.
So you're still calling it the game changer?
There's no question it's a game changer. We're seeing what Dr. Liegner is appropriately calling sustained remissions. We can't call it cured because we don't have a way to say there's no bacteria left in the body. But as you well know, and Dr. Liegner demonstrated in those first 3 patients that were published in July, people who couldn't get off antibiotics, people who kept on relapsing, are now off everything for a long time.
That's amazing.
It is amazing, yeah. And I'm going to mention that of my patients, of those 100 or so patients, there's 3 people I can think of who've needed to stop the disulfiram at very low doses. 2 of them because even at very low doses, the herxing was too severe that they couldn't take it. They couldn't take a once a week 25 milligram dose. And 1 patient had liver function tests that were increasing into the 300s, even though we were giving a lot of liver support. And I said, well, okay, we just have to stop. It was unfortunate. She didn't want to stop it.
I know, yeah. Herx issue or toxicity.
The first 2, it was a herx issue. Yeah, okay. A lot of inflammation in their bodies.
Yeah.
We knew that going in. And then the second one is toxicity, hepatic toxicity issue.
So what do you do for those patients? That takes us to how we're addressing side effects. You had mentioned several things. Stay on low doses for some, possibly longer term.
Let's just address that one. I'm thinking of 1 patient in particular, really lovely woman who a handful of imbalances that we're used to seeing in people with chronic Lyme disease complex. And she tolerated next to nothing that I recommended. It was really surprised me. I was giving her such benign supplements at low doses, and she wasn't tolerating them. She was hypothyroid, and she didn't tolerate most of the thyroid medications, even at low doses. I finally found one that she did tolerate it, and that did help her. And finally, we started the disulfiram, again, at a very low dose. She was okay. And we have left her on what I recollect as 31.25 milligrams every 3 or 4 days. And she has noticed significant benefit.
Good.
This is the first time she said she's had energy in years.
Yeah.
But because of her fragility, I'm just holding there. I'm going to hold there for 2-3 months. We'll see. We're going to play it by ear. But my instinct is if we tried to push the dose, she would have a herx, and then she'd have even more trouble tolerating the medication.
Yeah, because you have recovery to get through first before you can address the pathogen load again.
Yeah. And we've addressed it enough to decrease her systemic inflammation and alleviate a handful of symptoms. So that's it for now. We're not going to push it.
Yeah. So what does that look like when you see someone that's that fragile, struggling with disulfiram? How do you back up and help open up their detox pathways for an easier go at disulfiram when you get back on it?
Well, as I mentioned before, I often start people on a lot of detox support, but if they're really having trouble and it's available, I'll try to get them on higher doses of glutathione, intravenous glutathione, phosphatidylcholine, intravenous phosphatidylcholine, alpha lipoic acid. I will perhaps revisit their methylation pathway, see if there's anything we're missing, and binders, of course. I found that alkalinization, for example, in the form of trisalts, can be very helpful.
Very powerful tool. People dismiss it.
Oh yeah, and we still don't know exactly how it works.
Yeah, it's amazing, but we know it's alkalizing the blood, which lowers inflammation. So in my simplistic way of looking at it, I think that's enough for some people. And again, the powerful tool of detox bathing. I don't think people realize you're alkalizing your blood in a very quick way because you are trying to raise the heart rate with a detox bath. That's my purpose of doing them, is alkalizing the blood. So people who are really struggling and not realizing, it's right in their bathroom, and it takes away bad headaches and some major herxes, nausea, things that you wouldn't think a detox bath would help with, but it's the baking soda, peroxide, Epsom salt, the alkalizing agents that you put into it seem to. Do you prescribe that at all as a tool for your patients?
Yeah, thanks for reminding me. It is one of the first things that I recommend, particularly warm baths that have as much as 6 cups each of baking soda and Epsom salts. Remember that many of these patients have some dysautonomia, and if they're in a hot bath, they can stand up and pass out.
It's a safety issue. I did a video on it because of that issue. Actually, they need people with them to help them in and out. And if people have passed from having a seizure in the tub, I hate to say it, but safety is always my biggest concern because we can lose people quickly that way. And of course, that's why we want to avoid those situations, but not to dismiss the powerful tool that is cheap. And I like promoting things for patients who are treating Lyme disease on a budget. So one thing before we move on that I wasn't clear on, do you consider treating heavy metals, chelating heavy metals a big deal before because of the copper complexing and things like that might get us into trouble on disulfiram? It's indicated that it's a good idea to test them and then go from there.
And this is a really good question. I do test for heavy metals in many of my patients, particularly if they're having problems with detoxification. If they seem toxic for reasons that I don't understand, I will check their heavy metals. I won't do that right away, though, unless I have a real reason on the basis of previous tests or on the basis of history and exposure. I won't look at that right away. And this also brings up the mold issue.
Oh, thank you so much. We've remediated 3 times. It's a big deal for patients.
Yeah, it's important for patients to realize that if they have what I'm going to call Lyme Disease Complex, so it's Lyme plus co-infections, plus systemic inflammation, plus lots of organ dysfunction associated with that. So that's the nomenclature I'm going to use, Lyme Disease Complex.
Like that. I wrote it down.
Okay. So if they have that, I would say that half of my patients have issues with mold.
Wow, half, yeah.
And it's interesting to note that they might live in a pretty moldy house, not knowing it, of course, and they are the only ones that are sick. Their family members are not sick. Now, it's not healthy for their family members being exposed to mold and the toxins that are expressed by a lot of indoor molds. So, But the Lyme patients, the Lyme disease complex patients, they really have problems with that, and that's going to add to their toxic load, and it can even suppress some of the detox pathways. What I'm saying is, it's interesting to me that before disulfiram, I would treat both the mold and the Lyme simultaneously, but I might be more aggressive about the mold and particularly mold toxins, and doing mold remediation and so on
Right.
before being very aggressive with the antibiotics. Certainly, I know some people, some colleagues of mine say, well, you got to treat all the mold problems before you consider antimicrobial therapy. And I'm saying, yeah, but guess what? They can benefit from some antimicrobial therapy while we're doing that. I don't think it has to be to the exclusion of treating the infection. But I'm finding that disulfiram so effective, and it's so impressive how patients get on this, and now their systemic inflammation goes down, that I'm being a little more aggressive about using the disulfiram before I'm really aggressive about the molds. Now, I still want them out of a mold house. We still recommend total remediation. I still get them on binders, but I might not add a systemic antifungal or a nasal sinus antifungal and other issues that we address with the mold, and we might revisit that. But it's interesting that I'm finding people with mold issues who are simply doing very, very well on the disulfiram. So I'm not ignoring the mold issues, but I'm not being as aggressive with it as I was. But I will get more aggressive, certainly after they finish the protocol, the disulfiram protocol.
Okay, that's great. Are you giving confidence to disulfiram in helping the body get rid of spores then? So that's why you're lessening the treatment and you're increasing disulfiram versus the antibiotics. Very interesting. Yeah, I'm picking up on the undertones here.
Yeah, good for you. So, yeah, we know there's some data. As far as I know, it's limited to aspergillosis.
Yes, I read that. Yeah.
And as we know, that's one of the 3 most common molds associated with indoor water damage. So isn't that great that disulfiram happens to hit that too? Because I think systemic antifungals are very important to decrease the interior fungal load, which is continuing to propagate, of course, the mycotoxins. So yes, I am giving some credence to that. I don't have any more data on that than what.
That's okay.
Yeah.
Good information nonetheless. Okay, so just quickly before we move on, so you mentioned nasal spray binders for mold you might look into would potentially be something like cholestyramine?
That's interesting. There's a handful of toxin binders. Cholestyramine has been made famous by Richard Shoemaker. I actually don't use cholestyramine as a first-line agent because the majority of my patients don't tolerate it.
Really?
Yeah, significant gastrointestinal side effects usually, but also some systemic side effects, even though it's not absorbed. So I'll start with things that are easier to tolerate, and then we can always go to cholestyramine if we think we need some heavier binder usage. But yeah,
can you give us one that you have good faith in that's helping outside of cholestyramine?
Well, I'm using right now I'm recommending a supplement called GI Detox. And it has charcoal, it has clay, and it has a handful of others. And really I'm shooting from the hip here. But yeah, my presumption is that if we have a handful of binders, we're getting a broader spectrum of binding rather than just using one binder. People like Dr. William Ray, who's passed fairly recently, but has been at the forefront of
here in Dallas.
Exactly, here in Dallas, a wonderful man. He always suggested using at least 2 different binders to increase the spectrum of binding potential. I usually recommend twice a day, but even that's hard. Ideally 4 times a day, that's impossible. So
wow, okay.
Wake up in the middle of the night and they can take it 3 times a day, but usually 2 times a day, like mid-morning, mid-afternoon, is the most convenient for people, and they set an alarm on their smartphones to remind them because it's hard to remember.
I have to do that too. What type of blood work or testing do you run to help somebody open up their detox pathways if their endocrine system or if they're just not handling disulfiram well?
Well,
what would you do?
Again, I think the most important is doing a good methylation evaluation. And this gets really complicated. You know, the most common most common mutation that's looked at is the MTHFR, and that's a good place to start. But there's the MTR and the MTRR, and then there's a handful of other mutations. And I've found that for people who are really fragile and sick and not tolerating things well, I'll actually order intermediaries. So instead of looking at the mutations, we're looking at the different metabolites in the pathway to see what's low and what's high. And that gives me an even better idea of how can we supplement. And we have to supplement slowly for these people. You know, putting them on 5-MTHF sometimes can really crash people. And we presume that's because we're accelerating the pathway so much that they're dumping all of these toxins that we're collecting in their cells into their bloodstream, and that's much faster than they can excrete it. One of the metaphors I use for my patients is, you know, think of the cells as your office, your bedroom, and they're filling up the garbage pail with the toxins, and then suddenly all the rooms in the house are dumping those toxins into the hallways, and you know that's a lot faster than you can cart them outside to the dumpster. So we can sometimes have to go very slowly with this methylation support. That's the biggest one by far. Of course, I'm also.
Yeah, go ahead. I just think that's the biggest deal for me, myself, in my own treatment. I didn't feel good the whole 8 months I was on it. Been off it almost 3 months. I still don't feel good, but my neuropathy's gone. So I'm not complaining too much, but definitely that's where I'm at in my own treatment. If that helps anyone else out there in the community, is the detox pathways. So my next question then is, do you treat anyone for MCAS to lower inflammation? But I think people go into cytokine storm a lot quicker than they think they do when they start disulfiram and already have a high inflammation load. Do you treat MCAS to try and get a handle on that first?
Yeah, I'm glad you brought it up. A really significant percentage of my patients, and I wish I could give you a number, but it's certainly at least 25%, have issues with mast cell activation syndrome. And when I say that, they don't have the full-blown syndrome. You know, the full-blown syndrome, people have hives and diarrhea and chest pain and palpitations and headaches and flushing on and off all day. I mean, the list is really long, and they don't have that. But they'll have what's called a form frust of a syndrome. I don't know if that's Latin or French or whatever it is, but it means they don't have the whole syndrome, but they have parts of it. And they typically have dermatographia, which when you scratch on the skin, it leaves a red or a white line. They often have itching. They have inflammation, as you're suggesting. And when people have inflammation that's hard to control, even if they don't have obvious symptoms of histamine release, I will certainly try to intervene by inhibiting mast cell degranulation, using various types of antihistamines and so on. Sometimes people have to implement some significant dietary restrictions, and a full mast cell diet is really tough. It's really challenging, and it doesn't apply to everybody. You know, person A might have problems with tomatoes or avocados, but person B may not. And but the good thing about cromolyn and quercetin and ketotamine, these can help block mast cell degranulation in response to food allergens. Back in the days when I did environmental medicine, you know, and I had a lot more contact with the late Bill Ray, we used these interventions a lot in people with multiple food sensitivities. I can remember a patient who he would get, you know, severe reactions to, you know, a typical anaphylactic reaction to some shell food like scallops or something. He was doing so well, he really wanted to try eating it. So I gave him permission. I said, okay, you got to park or sit right outside an emergency room.
Yeah, you have an EpiPen on you.
Yeah, exactly. And that's what he did. But guess what? I can't remember. He was either on quercetin or cromolyn, and he had no reaction. it was pretty amazing.
That's pretty remarkable. So that's what I've been focused on since last summer with my family. All 5 of us have gone through my doctor's to have skin allergy testing, so that because I had 2 kiddos this year who had histamine covered torso, eyes, neck, but skin allergy testing I think is a really big, powerful tool that people seem to miss. That you have to get rid of the triggers. It's really helped. My other one had both teenagers on his hands and his feet, but that's it. They all struggle with Lyme and co-infections, and these types of things are a big deal in triggering and what flares. The other one was an 8 on mountain cedar. So every twice a year he'd get sick and it'd take him weeks because he's immunosuppressed. But again, now we're treating one of his triggers. So are you seeing that's a big part of preventing people from having the MCAS issues, is going after it that way?
Yeah, one thing I want to mention in terms of skin testing, it's a reasonable form of testing for inhalants. It is a reasonable form of testing for IgE-mediated food allergies, which I think you're describing, certainly eczematoid and asthma-type reactions, hives and anaphylactic reactions, although I don't think most allergists would want to test a patient with an anaphylactic reaction to a suspected antigen. But for the other types of food sensitivities, the ones that are delayed or not IgE mediated, we think most of them are IgG or IgG4 mediated, and which are not black and white, that might depend on how often we eat the offending food, or whether we eat the offending food in association with another food or stress or whatever.
Right.
The skin testing doesn't work for those. And there are blood tests, which I think you've also referred to. And the blood tests are great because you can test 200 items with a single blood draw. They're not perfect either. They're false positives and false negatives.
Okay.
I typically will use elimination challenge diets.
And then we're also doing the skin allergy shots at home. We're giving them at home. Our insurance has paid for almost everything 100%. Not that that would be the case for everybody else out there, but just to let people know, check, because it's a very, we haven't had very much illness this flu season at all in my home, and that's not typical. So
Yeah.
I attribute it to that small change. Next thing I wanted to ask was kids on disulfiram. I was surprised earlier in our pre-interview discussion that you mentioned you treat kids. Thank you, thank you, thank you. That's really great. As you know, not a lot of people are doing that. But what is your experience? I think you said 12 and up is what you might use disulfiram with in children?
Yeah. So these are, I think, around 12 years old and up. I always explain everything to the parent, and not only go into detailed explanations, but I actually have the patient sign some sort of waiver that says they understand that this drug is not approved for children, and that they give permission. So we treat the kids the same way, except that because they're smaller, we may start with a lower dose. But you know, what the heck? I mean, I see teenagers that are bigger than I am, so
Yeah.
often that the weight is not even an issue in my patient population anyway. And of course, I'm seeing benefits in those patients as well.
Oh, okay. Well, that's really great. So,
Well, I would say, let me caveat that. We generalize the dose.
yeah, that's true. Inflammation.
But we have to, you know, as we've already discussed, people have very different metabolisms. Their detox pathways work with more or less efficiency. They have different comorbidities in terms of their mold toxins or heavy metals, and as well as just other considerations. Do they have emotional support, et cetera? So, so it's not only weight that's going to determine dosing. You know,
Okay.
looking at the general constitution of the patient and what do we assess their tolerance will be for a antimicrobial treatment.
That makes perfect sense. Okay, and then are you using or recommending people use disulfiram in acute cases, do you use disulfiram in acute patients first, or do you go straight for the old adage, doxycycline?
Well, okay, great question. First of all, I'm not a big proponent of doxycycline.
No, I know. That's why I laughed when I said it. It's so old.
There's one benefit to doxycycline, which is that it will hit some co-infections. On paper, it'll hit Bartonella and Mycoplasma, but my clinical experience is it does very little for those bugs. And then it probably is the best treatment available, as far as we know, for Ehrlichia and Anaplasma. Ehrlichia, by the way, is generally from a Lone Star tick. Anaplasma is from the deer tick or black-legged tick. Rickettsia. So these are, in my experience, these are less common co-infections. So I usually won't use doxy. I won't go into the mechanisms of doxy other than to say it really doesn't work as well in terms of killing bacteria. On the other hand, what if we're using disulfiram? Well, we know that disulfiram is going to cover Lyme. We know that it covers Babesia. That's really great. We know that it hits Bartonella, but I can also say now with additional insurance that while it knocks Babesia down, it does not knock it out, which we're hoping it does for Lyme and Babesia. Right now, I haven't had, first of all, I don't see very many acute patients, maybe a dozen a year.
Wow.
Will come to the office. And as I mentioned to you earlier, they don't get on a waiting list. I stay late, get up early or whatever, get them in as soon as possible, because the sooner you treat, the better. And I'm trying to think now of that at least half of those patients have co-infections. And, we sort of tease that out in terms of history. Like, well, before I got this rash, or maybe even a bullseye rash, I was having nausea and vomiting and GI stuff. And guess what? That was probably Bartonella. Or they'll say, yeah, well, I got a rash, but then I started having these high spiking fevers and sweats and shortness of breath. Well, obviously they have Babesia and so on. So we try to tease that out historically. I won't go through the whole shtick of how we treat acute Lyme, but I will say that I haven't had the courage to simply put them on disulfiram. What I have been doing recently, though, is treating them the way I have been treating them with appropriate antimicrobials, and that's usually a minimum of 6 weeks for just Lyme, and usually a minimum of 6 weeks for Lyme, 3 months with co-infections.
Okay.
And that presumes it's totally uncomplicated. That presumes we get them antibiotics and they're totally asymptomatic. If they have 2 or more co-infections, it might be even longer. But at some point in that treatment protocol, I'll say, you're doing much better. We have a possibility of wiping out, and particularly the Lyme and the Babesia. We know that even though I don't think it gets rid of all the Bartonella, that's clearly the case in some of my patients who've completed a whole run on disulfiram. It's hitting it as well as the usual things we use, but I mean, even the infectious disease docs say, yeah, we treat it with triple antibiotics, but we don't know that we ever get rid of it. So it's one more thing I'm using to treat the Bartonella, even if I have more confidence in its impact on the Lyme and Babesia.
People are saying in our Facebook groups that Bartonella is flaring. Some of them say. When they're just on disulfiram, the conversation then circles around, well, do others do rifampin or Bioxin or whatever the other one is? Bioxin.
Yeah, Bioxin is clarithromycin. Rifampin is going to be more aggressive, better treatment. Bactrim, which is sulfamethoxazole trimethoprim, a sulfa drug, is also good. I think the combination of Bactrim and rifampin are very good. My experience is that they do not eliminate this bacteria. But here's what I do. Most of my patients, I'm already treating for Lyme Disease Complex. They have chronic infections. I start them on low doses of disulfiram. And they're not only on antibiotics, they're on antimicrobial herbs, some of which are alcohol-based, right?
Yeah.
So as we progress the dose of disulfiram, I start cutting back on the others. And often I can take people off of all of those other antimicrobials and they are doing great. But after they finish the course, they start to have some symptoms come back, and almost invariably it's Bartonella.
Bartonella.
Yeah. So it clearly suppresses the Bartonella, and I clearly see Bartonella herxes when taking disulfiram, but it doesn't seem to be eliminating it in my patients thus far.
I'm okay with that. If we can have some kind of treatment for the other two monsters of the group, I would call them, I'm pretty happy with that. This is finally, we have something that's working. Okay, so we have read some things about disulfiram's effectiveness against viruses, retrovirus, the HIV article that came out about the study that it takes the virus out of the cell and presents it to the immune system. That's my lay interpretation, but what are you seeing as far as it handling viruses and retroviruses? Anything you can offer there?
Yeah, this is an amazing drug. You know, next it's going to be mopping up our floors and topping on our ice cream. I mean, it's like crazy, all the things that this drug does. Those people who watched Saturday Night Live 30 years ago will recognize that reference. But here's what's in the literature, not just one article, there's more than one that suggests that what this drug does is it takes the HIV out of its latent phase.
Okay.
And then makes it more vulnerable to the antiretroviral drugs.
Okay.
I don't know anything really about the HIV treatment. I know about the drug and so on, but I have no expertise in that. Something I've seen in my patients, which is very interesting. I've had a few of them tell me that, you know, they have oral herpes, which occasionally would cause an outbreak. And what they see is that they get this slight eruptions and then they go away. And then a month or so later, they get some slight eruptions and then they go away. I suspect it's the same mechanism. Is it doing the same for Epstein-Barr cytomegalovirus or human herpes virus 6? I have no idea. You know, is it doing the same for parasites?
Yeah, it's a big problem because Lyme can hide in all of these things, including parasites. And interesting, just before we move on, I would get itchy herpes breakouts along my nose and around and through here when I had disulfiram, and very little of that since. But again, my biggest issue I was struggling with was neuropathy. Like, I was one of those patients, I thought I was pretty close to remission at the end of last year before but legs and hands not working when you ask them to. So neuropathy was starting and I didn't want it to progress, but those things are all gone. So it's interesting. It's quite a journey, but I've had it for 39 years. So I think someone for myself, my protocol is going to be doing a lot of these things that you're using with your clients and what Dr. Ligner has offered in information. But like you said, I love the reference. It is a dance that we quote you all the time in saying that it is a dance, because you have to kind of see how your body is going to respond to low dose. You can always go up. But I think I'll work on my pathways for a while. I'm doing homeopathic for my loads of Bartonella and Babesia. I still have low levels of infection after 8 months of disulfiram, but it brought a lot out. So I'm glad that it did, but I'm definitely not cured or in remission yet. I was herxing when I finished 60 days at 375. So I got off of that because of the herx and just was going to a Lyme conference. I wanted my brain to work. And so I'm glad that I did, but I do know I'll need to go back on at some point. So neurotoxicity, what side effects are you seeing are most common with using disulfiram? We talked quite a bit about that, and I just want to make sure we tap on that a little bit for patients.
Yeah, so going back to one of your first questions, this is a very potent drug and it has potentially potent side effects. And we really need to be aware of that and restating what we already have talked about, the need to start low and go slow. And my patients check in every 2 weeks. They don't increase their dose till I give them the go-ahead. That said, I don't see much in the way of central nervous system side effects, with the exception of sometimes at the higher doses. So they're moving along. They have some herxes. We're very gradually getting up to what would probably be an average of target dose of 250 milligrams. And some people, they might weigh around 150, 140, 150 pounds. They might be still having some symptoms. We'll start them on 375. We don't even start them on 375 daily. We'll start alternating 250 with 375 every other day. And then they'll say, well, you know, I'm getting some headaches and I'm depressed and I'm tired and brain fog and maybe some neuropathic symptoms, some weakness, some tingling, and so on. And as you know, I encourage my patients to contact me right away if they're having any symptoms, and they do. And I say, okay, stop the drug. Usually within 24 hours, people say, oh, I feel great.
Good.
So I give them 48 hours off the drug, and then I'll restart it at the 250 and say, we're not going to 375. I have some patients who say, well, I just have a little brain fog. I want to continue on this. And I'll say, no, I'm concerned because I know the potential of encephalopathic problems. And a little brain fog might mean, yeah, there's some toxic encephalopathy. It's not bad, but it could become bad. And I'm not going to risk that, because I know of people who, thank God, none of my patients, but people who push the doses higher than is appropriate, and they're now disabled. So I'm very, very careful. And I know some patients who've pushed the dose. They pushed it in two ways. One is they've started at a higher dose and they've progressed it too quickly. So for example, they've started at 125 a day, and after a week they go to 250 a day, and then they get up to 500 a day. I know of patients that have become disabled because of really severe neurological problems documented on various studies, and it's tragedy. I have seen some mild neuropathy sometimes before they get to the higher doses, and we push. First, I mentioned that they're already on zinc and vitamin C. I might push the doses of alpha lipoic acid. Intravenous alpha lipoic acid, by the way, is very good for treating neuropathy. It's a slowly increasing dose protocol that if patients have a doctor who does intravenous supplements, that's really a good option.
What do you start them at on ALA? Because I've done those. They take a while, but
I don't want to get into dosing on it. I think have different regimens, but it's very effective. It's very effective. Okay. And then there are other treatments for neuropathy that include intravenous vitamin C, and if there's a sensory neuropathy that is causing pain, there are neuropathic gels and so on. But if I start to see these issues, I'm going to cut back. And you know, I know when we talked earlier, you mentioned depression in some patients, and
I wanted to get to that for sure.
I haven't seen a lot, but I have seen some patients develop mood disorders. I consider this part of a toxic encephalopathic syndrome, and I'll immediately cut the dose on those people too. Even though, well, I can hack it, I can push through this, and I don't go that. We say no, we'll cut back. We're going to take it slow. I keep on repeating that the tortoise beats the hare, and better safe than sorry. Yeah.
So I've had benefit supplementing glutathione, liposomal liquid glutathione that comes with phosphatidylcholine in it. I get it right off Amazon. I'm not recommending that for anybody, and it's not my medical advice to anybody, but that's interesting that you mentioned that in ALA. And So these are all things that we've been talking about in our group. So thank you for confirming those pieces of information. Will be very helpful for patients. Okay, optic neuropathies. Are you seeing this more common than the literature discusses? Because it says it's rare. But I wonder if, the reference was from alcoholism use with disulfiram versus Lyme patients.
You made a very good point that what we know about disulfiram toxicity is in alcoholics. This is going to sound strange, but in general, I think alcoholics are a lot healthier than my patients. The fact that they can drink a bottle of wine, a 6-pack or more, geez, none of my patients could do that. I can't drink. Even off disulfiram, I couldn't have more than a few sips of any of those things without noticing the side effects. And that's true. Most of my patients don't tolerate alcohol. We know that metabolically their bodies have been stressed for a long time. We know they have systemic inflammation. We know that there's a lot of toxin buildup. So you're absolutely right that the literature says that certain things are fairly uncommon. Guaranteed they're going to be more common in the patient population that you and I know. And so we got to be more careful. There is a toxin-induced optic neuritis that is associated with disulfiram. I haven't had any patients in whom that's severe. I've had some patients where they're starting to notice a little blurry vision or something like that, and immediately I'll cut back.
Okay.
And do the things that we've already talked about to deal with inflammation and toxicity. And detox. Yeah, absolutely. I know I'm repeating myself, but better safe than sorry.
No, I appreciate that.
A couple things. One is it's important to distinguish what's caused by the bugs, the Lyme Disease Complex, and what's caused by the drug. Okay. As you're suggesting, people can get all sorts of inflammatory disorders of the eye that can affect vision simply from the infections. And they can also get a toxic optic neuropathy from the drug.
Side effect, yeah.
Yeah. So, those are two different pathophysiologies. I would wonder in your case, with symptoms coming back, is that simply Bartonella? Given how long you've been on a target dose disulfiram, and you're having symptoms that are particularly neurological, which we know Bartonella does more so than the other bugs. It's not that the other bugs don't do it, but Bartonella does it most, and Bartonella is not 100% treated in my patients anyway by disulfiram. So and that's what I'm used to seeing. I'm used to seeing that patients feel great when they finish the protocol, and then within weeks they start to notice some symptoms coming back, and they can identify them. They say, "Oh, I think my Bartonella is coming back," and we'll put them on rifampin or whatever, and see what happens. And generally they respond.
Okay. Well, for now, I'm doing homeopathy, just biohomeopathy for Bartonella, Babesia, and Lyme. Just giving a break that tends to be a gentle way that my body is able to deal. But sometimes I do require more. But I'm treated 7 years. I've gone that route many times, having a port and a PICC line. I've done it all, I think. But so we're getting pretty well into our interview. Depression has been such a big issue for patients. I know we talked about it already. Is there anything else you want to add as far as, I take this very seriously. I think that people who have a family history of psychosis or schizophrenia or bipolar, the studies show tend to have more likelihood of potentially having a problem on disulfiram with those things. What have you seen, and what can people do ahead of time? That mentioning one, just explore your family tree. That might be, helpful to people that are considering getting on disulfiram. But So many people are scared of the psychosis or scared of depression, getting on disulfiram to help get rid of these infections. What would you say to them that they can do to help mitigate having that as a potential?
Okay, a good question, of course. All the issues we talked about before in terms of improving detox pathways, adding detox support, decreasing inflammation. Remember, a lot of the pathways that result in problems are inflammation, and so I recommend a lot of CBD and other anti-inflammatories. These are things I do in most people, and frankly, the majority of my patients have mood disorders that I think are simply part of neuropsychiatric Lyme.
I think so too.
Yeah. So the anxiety and depression and irritability, which can be panic attacks, suicidal depression, and rage, all of those things. These are not uncommon in my practice. But if things are going well and they develop depression on the medication, I consider that a neuropathic problem. I consider that possibly a drug-induced encephalopathy. And I'll immediately cut the dose back or even stop it a few days or a week. Depression is awful. It's not only depression. Some people suddenly have severe anxiety, mood swings. I see that occasionally, not a lot, occasionally. And again, I'll immediately stop, and then it does go away. And then we'll restart at a lower dose and see if there's anything we need to do to support those pathways we've already talked about.
Good. Okay. Do you ever refer anyone to a psychologist for things like a Fexer or anything that's going to help balance the brain as far as the depletion of norepinephrine and balancing serotonin, the things that can be bothered by disulfiram? I'm just wondering, I know, do you ever do that, or do you go at depression by way of checking their thyroid levels?
Depression is miserable, no doubt about it. Again, most of my patients have mood disorders but when they walk in the office, right? It's unusual that there's not something going on, and often it can be the primary complaint. So we need to distinguish, is this a mood disorder, a primary mood disorder? Is this a mood disorder that's really secondary to neuroinflammation? And then, is this a mood disorder caused by the drug? Now, the first two, I really don't have a problem making that distinction. Oh, this is part of a complex of symptoms. This is neuropsychiatric Lyme, and this is something that we expect to get better as we treat those infections, and they do. Now, some of those people, though, because of the severity of their symptoms, will be on pharmacologic treatment for those symptoms because they're so severe. So some of those people are going to be on antidepressants and anti-anxiety agents. I will point out that CBD is a really, really good anti-anxiety agent.
And very natural, and it helps with pain. Yeah.
We could have a whole program just on CBD.
Well, yeah, it's been a very healing. I couldn't have done Lyme treatment without CBD.
So I recommend CBD the vast majority of my patients. Again, we can discuss that at another time, but my point is that we're already dealing with their mood issues before we start disulfiram. And if something happens while we're progressing the dose, that suddenly they become more depressed, I consider that more than likely caused by the drug. And that would be part of a toxic encephalopathy. And like I said before, I will stop the drug, wait a few days or a week, and reassess at that point. But I'm very, very careful, always better safe than sorry, because of the potential severity. You mentioned psychosis and so on. There are other issues with toxic encephalopathy that can put people to bed.
It's scary. It's real scary for patients, and my heart goes out to people. I'm super conservative. Everybody was talking about starting at 125. I started at 62.5. I stayed off disulfiram for almost 6 weeks because I wanted to make sure all inflammation was down before I caused more. I think people don't give it enough importance. I want people to get through this as safely and as comfortably as possible. Depression has been a big part of the question as to how to do that on Disulfiram. So, okay, so your ideas are, before they start, is working on those detox pathways, binders, getting rid of as much inflammation as they can with the turmeric, curcumin, all that stuff you mentioned. Before they start, that's a really great approach, because I don't think people associate depression as a high infection type of a syndrome or symptom of high infection, and it a lot of times often is.
Okay, so certainly once they reach my office, they can be relieved to know that, oh, you're not crazy, you're not just a depressed person, you know, you got inflammation in your brain, and that's very reassuring to patients, and that it will get better, and that some of them will need some psychotropic intervention before we start doing much else. And I have some of the kids I see now, these are kids mostly younger than the 12-year-olds who have PANS type syndromes and have real violence. I mean, some of them are on antipsychotics, and that's a whole other.
Yeah, that's a big deal for a kid.
Yeah. I want to also mention, you know, that you had your thyroid check. Every one of my patients, the first time they come in, we evaluate their thyroid and so on. These are all things that should be done as a baseline in anyone with a chronic illness.
So touch on that real fast, because that's definitely a big part of my ending notes, but that's why it's so important that a patient that wants to do Disulfiram works with a medical professional for those reasons. Safety is the biggest concern, but so that they can monitor them. And what else? Well,
when patients first come in, what I do is medical detective work, right? And what I'm looking for is patterns. And we go through their entire history in ridiculous detail. Patients say, wow, that, you know, never went through that before. And then we assemble lab data that was previously done and stuff that I order. And I can then put together this landscape and say, well, okay, you know, your adrenals are a little low. They've been working really hard. They've lost some of the reserves. The thyroid gland seems to be working well, but because of the inflammation, your T4 is converting more to reverse T3 than it should, and that's inhibiting the impact of T3 at the cellular level, and we can bump that a little bit by adding liothyronine. And we're looking at the methylation pathways. We're looking at food sensitivities. I will mention that at least half of my patients are sensitive to gluten. They don't have, occasionally celiac, but mostly just sensitive to gluten. I would say the two other most common food sensitivities are dairy and eggs, but it could be anything.
Corn is another big one, peanuts.
Absolutely. So, you know, we go through the whole shtick. They might have, you know, SIBO and other. I have patients, blows me away. They were seen at the University Center in UCLA years ago, and they did some blood tests, and the patient has fatigue as well as 24 other symptoms. And they do a B12 level, and it's 150. And they say to her, oh, take some B12. Well, excuse me. You're eating meat, dairy, or eggs. If you're not a strict vegan, you're getting B12. And if your B12 level is 150, which is really low, that means you can't absorb it. And she has pernicious anemia, and she goes years without treatment by more than one university medical center. I mean, these are basic things that we can check. You know, and then, so there's all sorts of digestive claims. Basically, we're looking at all these different issues, and it can seem overwhelming to patients when I introduce it, and I reassure them. I say, look, I know this is complicated. I know it seems overwhelming to you, but I can tell you it's not overwhelming to me. I can see the patterns. And so while we separate out these patterns and put these different labels on the issues, then we integrate the whole thing and say, okay, here's where we start. We don't address this all at once. And we're going to do one thing at a time. I tell my patients, we always stagger interventions. We never add two things at the same time. We're never certain, even in the most benign supplement, that you're going to tolerate it. And to reassure them that, I'm going to say this for the upteenth time, the tortoise beats the hare. And people do well. And if they might need a psychiatric referral, you're right. But most of those people, they've been to the psychiatrist already. That's the first place they were sent when they saw their internist or whatever, because they said, oh, yeah, well, you're depressed or you're anxious. And they get labels like generalized anxiety disorder, major depressive disorder. And like, what's that? It's just a descriptor. It's a descriptor.
It's a symptom.
Yes, exactly. And so it's treated. And I don't have anything against treating symptoms.
Right.
If you can help people feel better without causing other problems, do it. Absolutely. If pain medication is needed, do it. Absolutely. But what's the underlying issue here? And what's underlying that? So, these are the steps we take. And eventually we take a person and help them, put Humpty Dumpty back together again, and they got a life again.
I'm so glad you took off the overwhelming part for the patient, because that's how we all feel. I finally told my doctor in the beginning, stop testing me for things. It was overwhelming me. I had way more than 3 lifetimes of a person could treat on my plate at the time. But, that's the story of so many patients that you have seen. I just remembered we wanted to talk about it's gotten popular, the discussion about enteric coating, where we discussed it might be as or better to take disulfiram with food on a full stomach because of the digestion. And would you discuss that for a second?
Yeah, we can discuss it. And I can also start off with the discussion with saying we don't know yet what's best.
Yeah.
I've been back and forth with Dr. Rajadas about this. He confirms that stomach acid will help convert disulfiram to some of its metabolites, and these metabolites are toxic. They can cause some of the neuropathic symptoms. They can inhibit the dopamine beta hydroxylase that can cause psychiatric issues and so on. Well, then he said, Dr. Rajadas, if I understand him correctly, said best to take on an empty stomach. So my question is, wait a minute. If exposure to stomach acid is going to convert these to potentially toxic metabolites, why aren't we taking it with food? Because an empty stomach is going to have acid there that is not being buffered. I'm still back and forth with Dr. Rajadas. He is doing experiments on this, and I think it's very important. In the meantime, I can tell you what I'm telling my patients. I'm telling them that I think they should take it with food, and they take it with their zinc and vitamin C also, which some people have problems if they take those on an empty stomach. So great, take them all together with food. I also tell people to split the dose. Do we have real hard data that that's better? No, but what I can tell you clinically is people say, oh, yeah, I feel better when I take 125 twice a day instead of 250 once a day.
I noticed a difference.
Yeah. So
lessens the side effects and the herxing.
Yes. So that's what I'm doing. And and it may simply be that it's absorbed slower, and maybe that's the only reason that it lessens side effects. Whatever. I'm basing it on the feedback I get from patients. So right now, and this may be subject to change, I'm recommending that people take the regular tablets, cut, and take it with food, along with their zinc and vitamin C and so on, that they split the dose if possible. I don't particularly recommend liposomal disulfiram. I don't really see the point. If the issue is getting it to the cells better, I'm saying, wait a minute, this stuff
already is.
It's pretty potent. I don't think we need to do that. So that's the situation.
And then, okay, thank you for all that. We'll see how all that pans out. I know Dr. Rajadas is a brilliant researcher. He'll figure out, I think, how absorption and metabolism will best suit us. Stomach health is such a big deal. I would say maybe even second to depression. So many people have just a botched immune system from the biome is just upside down. I
had quite a few patients say, well, antibiotics suppress the immune system. Antibiotics do not suppress the immune system. Some antibiotics are anti-inflammatory.
Oh.
Motrin is anti-inflammatory. They don't suppress the immune system. And I wish people knew that. Now, are there potential problems with antibiotics? Absolutely. The biggest one, of course, being the gut. And then we have to always be aware that some can affect the liver and the kidneys. Yeah. And while we've been referring to antibiotics and you've been referring to homeopathics, the truth is that most of my patients, I'm generalizing now, it is because it's all over the map. And as you know, every patient is different.
Right.
Most of my patients are on some combination of antimicrobials. And even though they may start on prescription antibiotics, we then start to put herbs in and eventually taper them off the antibiotics. So they can be controlled simply by antimicrobial herbs. So it's interesting, I have more patients that don't tolerate the herbs than that don't tolerate the antibiotics. But some people who don't tolerate the antibiotics, that's fine, we use the herbs. Basically, we use whatever we have, and we always stagger the onset to see what happens. I used to, with some of these herbs, particularly white remedies, which are really potent, but some of the others are as well. They react at 1 drop. I used to try, try half a drop, try a tenth of a drop. I don't do that anymore. If they react in 1 drop, they're not going to get any benefit from that intervention. So we work on whatever they tolerate the best, but eventually I try to get them off the pharmaceuticals.
Are you seeing something change in your patients since the last time? Because it's been 3 months since we did our last interview.
So what I want to impress though is I don't start 2 interventions at once. I always stagger interventions.
But you do use vitamin C during Disulfiram, and you haven't had significant increase in herx that causes you to not use it.
I don't believe vitamin C causes herx reactions. Oxidation therapies are hyperbaric oxygen, ozone, ultraviolet blood irradiation. So those can cause herx reactions. Absolutely. Yes. I have patients who actually are doing quite well on some of those. And often that's where we go if they're not tolerating any of the antimicrobials. Where I've seen the best responses is a combination of intravenous ozone compared with ultraviolet blood irradiation. It's very interesting in terms of how do these work. You know, they do have some antimicrobial properties. They do seem to stimulate immune system. They actually stimulate our own antioxidant system, you know, which includes vitamin C and so on. One thing I want to point out is glutathione. When I test people for their intermediaries in the methylation pathways, often their oxidized glutathione is high, but the reduced glutathione is low. Now, it's reduced glutathione that can quelch a free radical issue. When it does that, it is converted to oxidized glutathione, and then we need to help it get back to its reduced state. And this is where vitamin C, vitamin E, and selenium can help. So these are supplements that we often use with people who are having problems with detoxification, but it can be clarified by doing an analysis of these intermediaries.
Okay, very interesting. And then extending back to our point of stomach health on Disulfiram, do you use probiotics? Has that changed at all?
Yeah, this is still an unknown. You know, it's claimed. Dr. Lewis said this to me, and I see where he's printed it as well. He said, "Well, it's not an antibiotic; it's not going to affect the microbiome, but it is an antibiotic." And we know that in addition to Lyme and Babesia, it hits some gram positives like staph and strep. And so we don't really know its impact, but I do recommend that people take probiotics.
Stomachs are pretty trashed. So regardless of the effect of Disulfiram on the microbiome, and then what about the GAPS diet? That's been a really big game changer for me and so many people when I was struggling initially.
I will mention that as far as the stomach is concerned, I see a lot of people who don't make enough stomach acid. People with pernicious anemia, none of them make stomach acid. That poor woman that I mentioned who had a B12 150, she doesn't make stomach acid. Okay, stomach acid is important for a number of things. Stomach acid is necessary to absorb most mercury and calcium and all these minerals. It's important for breaking down protein, and you could actually become protein deficient without stomach acid. It's important as a barrier protection. It actually kills bugs, including parasites, that we don't want to get to our intestines. Sadly, a huge part of our population is put on PPIs, protein pump inhibitors, and that makes the problem even worse. And I'll get off my pedestal on that, other than to say I think those drugs can be dangerous, and people take them for years and years, and their gastroenterologists say, oh yeah, fine, and it's not fine at all. And maybe that's one of the reasons we're seeing more problems with SIBO, with small intestinal bacterial overgrowth. And this is where the GAPS diet comes in particular. And there are different diets that helps these people, and it might depend somewhat on whether they have overgrowth of hydrogen producers versus methane producers. And most of those people, guess what? They also have fungal overgrowth. And guess what? They probably also have parasites. All of those things need to be addressed.
And the GAPS diet, if you really do it pretty stringently, you'll have a detox of parasites and a lot of mood disorders, schizophrenia, ADHD, a lot of things like that are addressed through the theory of working the GAPS diet. It's pretty powerful stuff, and again, very inexpensive to do. Meat broth is a really big deal for people and rebuilding the gut. Is there anything else that you're seeing in your patients that you want to discuss today? Of course, we are together trying to get out the message of safety, caution, tortoise beats the hare mentality. Back up before it gets out of hand is what I keep trying to. If you get a herx of any kind, that's a message that, you know, you're producing more histamine and inflammation is high and you want to not produce more.
So I would say there's a couple things. When I see patients for the first time, like yourself, they've been sick for years, often decades. They've been to a lot of doctors. And frankly, I think they're heroes. Like, they're heroes because they haven't just submitted to what their doctors told them when they say, oh, it's all in your head, or you got fibromyalgia or whatever. And they know that's not right. And they keep on looking for other answers. And they trust themselves more than this so-called authority. And I think that's wonderful. On the other hand, they are depressed. But, you know, again, most often the depression is the worst part of the depression is because of the neuroinflammation, but it's pretty upsetting having a chronic illness that no one is addressing and being dismissed by multiple authorities and particularly academic centers. I've yet to see a good response from an academic center. And
right.
At any rate, so my role here is not only to evaluate and give recommendations, but it's to give people hope and say, I understand what you have. And it sucks. But I think it's much more likely than not, you're going to get better. And just stick with it and be willing to take baby steps. But I really believe you're going to get better. And the second part of that is the necessity of being available. So as you know, I just got back from a trip to Israel and Jordan. But guess what? I check my email every day. And my fantastic secretary, June, is processing phone calls, etc. It's very important for these people who do need hand holding. It's appropriate for them to have their hands held. And they are anxious about, well, wait a minute, I did this and that happened. What's next? And then, you know, my promise to my patients is almost certainly I can get back to you within 24 hours. And that's really important in this population. In general, it's important for the disulfiram population in particular because of the potential toxicity. Or if someone has a major herx, I'm saying, no, that's not good. I don't want you to push through this major herx.
Right.
Stop it and start at a lower dose. And they sometimes need to hear that more than once. So those two attitudes, one is one is there's hope, and we can deal with this. And the other is I'm at your back. I'm supporting you, and I will be available to you.
That's very commendable.
Yeah.
Yeah, really commendable, especially on vacation. I just can't praise you enough, and your office, your staff, for doing what y'all do. All Lyme doctors. It's such a complex illness. And I wrote a note here. You're really setting the pace, Dr. Kinderlehrer, for other Lyme doctors, but really anyone who sees patients that are not getting better. Don't just throw a drug at it, because that's not digging into why the body is speaking. So I think that's real important. A lot of this you're putting in your book, Recovery for Lyme book. Can you tell us a little bit more about that? It's exciting news.
It's very exciting. I've been working on this for over 4 years. It's now in the hands of my agent, who's presenting it to publishers. My title, which will probably be changed by the publisher, my title is Recovery from Lyme. The subtitle is The Integrated Medicine Guide to Diagnosing and Treating Tick-Borne Illness. It's a long book. It's I think at last count it was like 475 pages.
Wow.
But
another monster of great information.
There's a huge amount of information, and it's designed both for practitioners and patients. So what I've done is said, well, listen, I've been in a place where, I've accumulated a huge amount of clinical experience as well as serious medical training. And I really want to pass this on. And it's a lot of doctors, they train with me and they don't have the information that I have. And I'm not going to be around forever. So, so I'm writing this book in a way that doctors can see, oh, here's how I can recognize an issue. Here's how I can evaluate it. Here's how I can treat it. But it's written in lay language and has a lot of case histories that I know the patients will identify with and say, oh, that's me. I have that, just like that. And this brings up things that come in the book. I mentioned that half of my patients with acute Lyme have co-infections. Well, a third of my patients with acute Lyme also have chronic Lyme that was undiagnosed. But I take a whole history, and it's like, well, 10 years ago when you started getting anxiety and panic attacks and some fatigue and joint pains, you got it then, and you got it again now. So, this is, there's just a lot of stories in the book and a lot of details about how to deal with it. Earlier, I used the phrase, I think, that we try to pull apart the different problems and then put it back together. And that's what the book does.
That's amazing.
Yeah.
It sounds very helpful.
Yeah.
Well, good for you. I can't wait to get my hands on it and see what your approaches are, more so than what we've discussed in our 2 interviews. So your articles you've written about Disulfiram and Lyme disease are hosted on my website. I wanted to mention for patients who might be interested in finding all of these wonderful pieces of information in one place. That is disulfiramforlyme.com. And last but not least, you're taking new patients, but it's not quick.
Yeah, and that's really sad. My patients who are calling in, and there are quite a few, as you can imagine, we tell them we are taking new patients, but we're not scheduling them, that we can put them on a waiting list. And we give them a list of other doctors in the Colorado area, even though, people are calling from all over. And doing our best, yeah. Yeah,
and what is the office phone number?
The office phone number is 303-444-4877.
Wonderful. And your book is going to probably be titled something along the lines of Recovery from Lyme book. And I love the approach that you're taking along with the disulfiram treatment for Lyme. You've been quoted all over Facebook, and it's just such a gift that you're giving patients who have lost hope, that there is hope. And again, I'm not promoting disulfiram or any lab or any protocol. I am advocating for Lyme patients to have a treatment. I think every patient deserves to have hope, and a treatment is is the fastest way to get there. So thanks so much for all that you do, Dr. Kinderlehrer. We appreciate all your time that you spend with us.
Thank you, Christina. Thank you for what you do. Really appreciate it.
Well, thank you. It's my honor having 4 kiddos that got Lyme from me gestationally. It's the least I could do to pay it forward to all the people who have helped me and my kiddos get up and back to school and work and sports. We're an athletic family again, and that's a pretty amazing thing as a Lyme mom to be able to say. So I just want to share all of that with the Lyme public, that they can get better, and our lives aren't perfect by any means, but we're out of bed daily and ourselves out of this hole. And Disulfiram is definitely part of that. I think with my insurance, I paid $10 a month for my treatment. That's unheard of. I think we've spent hundreds of thousands of dollars. I would be sad to add it all up, to be honest, but I know it's quite a bit treating 5 people. So I want to help other families avoid that. All right. Well, Happy New Year to you, Dr. Kinderlehrer. God bless you and your wife and your staff. And I'm sure we'll be speaking again, maybe meeting back up around about CBD or something else that patients come up with that's important to talk about in the near future.
Okay. Be well. Bye-bye.
Thank you. You too. Bye-bye.